This work initially proposed the design and deployment of a low-cost, socially assistive robot in low-income elder care facilities, such as a PACE center, considering relevant tasks determined by our previous study to be performed by the robot to meet the needs of all stakeholders, which are the clinicians, caregivers, and the older adults. Although the need for further testing a low-cost mobile platform capable of human-robot interaction in elder care settings remains, due to the current global COVID-19 pandemic and its extreme effects on older adults, especially those living in nursing homes and PACE centers, led to a pivot in our research question. We are combining this assistive technology and its use in aiding the wellness screening for COVID-19 symptoms in older adults in these settings. As a result, a different approach towards investigating preferred features in service robots for older adults will possibly require either hardware modifications that account for physical distancing and easiness of sanitation, or endowing the robot with vital signs measuring devices, for instance. Although the type of interaction itself should be adjusted to essential tasks due to the pandemic. Therefore, a task able to combine approaches with objective, subjective, and behavioral measures can achieve the initial proposition of deploying a SAR system at an elderly care facility. Despite this new approach being motivated by the current pandemic, the screening approach will also be useful during the annual flu season, which also threatens the older adult population. Our current platform consists on a fully custom-made robot with the following hardware features. It consists on a holonomic base which achieves holonomic motions for the upper torso, a spherical projection head, non-functional arms designed purely for gesturing motions, and also an actuated spine that allows the robot to lean forward or backwards and inherently stabilize possible motion vibrations. We propose modifying the current version of the robot with the addition of RFID or radio frequency identification for personal identification, as the subjects will most likely be wearing face masks, which also may impose challenges to the implementation of facial recognition, although we might also attempt to do so. The check-in procedures will most likely require dialog and indication of directions, but an autonomous navigation may not be required. Therefore, we also propose modifying the current version of the robot with a purely rotational base. As one of the biggest indicators of COVID-19 symptoms, fever can be tracked in a contactless manner by the addition of a temperature screening device. Finally, disposable sleeves can facilitate robot sanitation, as the arms can be more susceptible to contact even if unintended. The current COVID-19 screening procedure at the PACE Center is shown. A total of 3 people interact with the older adults from arrival to being granted access to the facility or sent home, depending on the assessment of their symptoms and body temperature measurement, which is repeated at most twice. The new proposed procedure will combine this assessment with one conducted by the robot, having the 3 different interactions randomly alternately presented to the participant to capture the different desired measures and avoid any other effect to the study. The qualitative data will undergo a conventional content analysis. Additionally, an observer survey will inform the research team of additional reactions of the older adults while interacting with the robot. The evaluation criteria will include initial greetings and response, facial expression, such as whether the older adult smiled, was neutral, or frowned during the interaction, difficulty or lack of during the interaction, following instructions, and observer interaction, either actively or by the robot error during the interaction. The outcome of the study will inform us comparatively how likely are the older adults to be assessed by a socially assistive robot, and furthermore, how equal or distinct are the screening results obtained from the human assessment and from the robot. Finally, we will determine which modifications may be necessary to improve overall acceptance and trust of the socially assistive robot among the older adult population in community settings.